Hey, Rob Fitzgerald again. Thanks for tuning in, talking about toxicology, and specifically we're talking about toxic alcohols. We're talking about alcohols in general. They're all toxic depending on how much you drink. So starting out with ethanol, it's a simple primary alcohol. It's converted into acetaldehyde, so it gets oxidized by an enzyme called alcohol dehydrogenase. And in that process, we form reduced NAD. So we form NADH. Acetaldehyde is further oxidized to acetate by aldehyde dehydrogenase. And again, we're forming more reducing equivalents. Acetate is a carboxylic acid. Typically, you don't get acidotic from drinking ethanol because acetate is a substrate for the Krebs cycle. So in the case of ethanol metabolism, this metabolite gets further metabolized so it doesn't build up. And so we typically don't associate ethanol with an acidosis unless they're starving and you get, an alcoholic acidosis that's sort of independent of the metabolites. So you start to break down other substrates for energy, and that's how they become acidotic. So thinking about it, there's a couple of things to know. This enzyme, alcohol dehydrogenase, can be inhibited by a drug called fomepizole or 4-methylpyrazole. And we don't use that in the case of ethanol, but in some of the other toxic alcohols, it's the metabolites that are toxic. So we can use fomepizole to inhibit this enzyme and prevent the formation of toxic alcohols. So ethanol is going to cause an osmolal gap because it's contributing to the osmolality, but it typically doesn't cause an anion gap because acetate gets further metabolized. The aldehyde dehydrogenase step can be inhibited by disulfiram or antibuse, and what they're doing, the purpose of that is if you inhibit this enzyme, you build up acetaldehyde, and acetaldehyde causes unpleasant effects. It causes people to turn red and flush and feel sick and throw up, and so that's a treatment for one treatment for alcohol. So disulfiram works at the aldehyde dehydrogenase step. 4-methylpyrazole works at the alcohol dehydrogenase step. You take enough alcohol that you saturate the enzyme, so you have zero order kinetics, and you excrete about 0.01 to 0.02% weight by volume per hour. And so that's the legal terms. If you've been accused of driving, it's 0.08 percent weight by volume. And so in the cases of the clinical setting, we talk about milligrams per deciliter, and so 0.01 would be 10 milligrams per deciliter per hour. So that can be, you can induce that. You can also, if you have trashed your liver, you can have slower metabolism. One of the things that people are concerned about is, was someone drinking in the past? Typically with alcohol, the alcohol is cleared within 24 hours. So if you're trying to figure out if somebody is a drinker or not, biomarkers are ethyl glucuronide and ethyl sulfate. They're minor metabolites of ethanol, but they last longer, so they stick around and can be measured. One that I'm not going to talk about is phosphatidylethanol. PEth is a third one, but it's not as widely used. It lasts a little bit longer. So as I said, ethanol is cleared in about 24 hours. These last for maybe a week, something like that. And it depends on what kind of a cutoff you use for a positive result as to how long they can be detected. Your gut is forming ethanol, and so you do have very, very hard to measure concentrations of alcohol you produce endogenously. That's why you have alcohol dehydrogenase, or at least one of the reasons. And so we have to set a cutoff. And so typically the cut points are set at 500 and 200 nanograms per mil to reduce false positives. In the setting of COVID, everyone is smearing alcohol-based sanitizers on their hands, and in fact that does contribute to these biomarkers. Typically it's well below these thresholds, and so they are useful for determining active drinking. And so that's pretty much what I was just summarizing. So methanol is a toxic alcohol. It causes a metabolic acidosis, so it's going to cause an anion gap as well as an osmolal gap. And so we'll talk about the reasons for that in a minute. Metabolites also are very good methylating agents, and so they methylate proteins, and one of the adverse effects of that is that patients go blind because of that. 30 mils can be fatal, so it's quite toxic. 30 mils is a little more than a shot, so people can get into trouble, especially kids, if they are small and drink methanol. Treatment is really designed to block the metabolism. Methanol itself is not that toxic. It actually does cause people's central nervous system depression, and that's why some people drink it, but it's not a wise thing to do. So a couple of ways you can do that. You can inhibit metabolism by competitively inhibiting it by giving them ethanol. So you give them an ethanol drip to get them up to 100 or 150 milligrams per deciliter, where 80 is legally drunk, so that's a pretty good dose. And alcohol dehydrogenase works. It prefers the substrate. Ethanol fits better, and so it competitively inhibits the metabolism of methanol, and you can dialyze off the methanol. Or they can pee it off or breathe it off, depending on how severe the intoxication is. So ethanol is one way to do it. Another way to do it is hemodialysis. Hemodialysis is going to do a couple of things. One, it removes small molecular weight compounds like methanol. It also helps correct acid-base imbalances, and so that's indicated if your methanol concentration is above 50 milligrams per deciliter. 4-methylpyrazole is our alcohol dehydrogenase inhibitor. It works similar to ethanol, but it competitively inhibits at the alcohol dehydrogenase step. So methanol is a 1-carbon primary alcohol, same enzyme that metabolizes ethanol, alcohol dehydrogenase, but now we're forming formaldehyde. Formaldehyde is a very good methylating agent. In the chemistry lab, we use formaldehyde to add methyl groups to things, and that's what it's doing to proteins. So methanol is being oxidized. We're forming reducing equivalents. Methanol gets further metabolized by formaldehyde is an aldehyde. It gets metabolized by aldehyde dehydrogenase to formic acid. And the problem with formic acid is that humans don't have a way to further process this. And so this is the end product of the metabolism. Unlike alcohol, which goes into the Krebs cycle, we don't have a way to deal with formic acid. And so that's going to cause a metabolic acidosis. So methanol is going to cause both anion gap due to the anions of formate, as well as an osmolal gap. Isopropanol, people drink isopropanol. It's used in the lab to fix tissues. It gets metabolized to acetone, and we'll review that for a second. It fixes tissues like your GI system, so they oftentimes get GI bleeds, makes people burp. Unlike the other ones, this is a secondary alcohol, and so it's still subject to alcohol dehydrogenase, but instead of forming an aldehyde, we're forming a ketone. And so acetone is the end product of isopropanol. And so isopropanol is not going to cause an acidosis because this is a ketone and not a carboxylic acid. And so that's a primary difference between isopropanol and methanol or ethylene glycol. We think about the CNS depressant effects to be about twice that of ethanol. Same thing, we're forming reducing equivalents. Ethylene glycol, it's antifreeze. It does cause CNS depression, so people drink it for the effects, but it has toxic metabolites, and it causes both myocardial depression and renal necrosis. Ethylene glycol is similar to methanol in that its metabolites are toxic. It's also going to cause both an anion gap and an osmolal gap. Isopropanol is going to cause an osmolal gap, but not an anion gap. Same with ethanol. The problem with trying to detect ethylene glycol by an osmolar gap is that a toxic dose of ethylene glycol doesn't increase your osmolality that much, and so sometimes it's hard to pick it up by just looking at an osmolar gap. It causes hypocalcemia for reasons that we'll talk about. 3 stages of intoxication. It's a central nervous system depressant. It's being metabolized, and it's being metabolized into toxic metabolites. Excuse me. It causes cardiotoxicity because it is a calcium chelator, and so it causes hypocalcemia, and if you need calcium for proper contraction. The renal stage is a day to several days later, and what's happening there is that chelated calcium is precipitating out into the renal tubules and causing glomerular damage. The crystals, it's calcium oxalate, can be visualized on tissue slices. They also can be found if you're doing a urinalysis. So treatment is going to be very similar to what we do for methanol. We're trying to prevent metabolites from forming. So ethanol is one way to do it. 4-methylpyrazole is the same mechanism, inhibiting competitively alcohol dehydrogenase. Bicarbonate for the acidosis, calcium, if necessary, for the chelated calcium that's being lost, and hemodialysis. And so hemodialysis is going to be effective at restoring our electrolyte balance, our acid-base balance, as well as removing both ethylene glycol as well as metabolites. So it's similar to alcohol. It's a 2-carbon alcohol, except it's a dialcohol. So you have alcoholic functionalities on each end of the molecule. It's the same enzymes. So alcohol dehydrogenase, we're now forming an aldehyde. The aldehyde is acted on by aldehyde dehydrogenase to form a carboxylic acid. And we continue the same metabolism on the other end, same enzymes, alcohol dehydrogenase, and now we formed oxalic acid. And so that's going to contribute to the anion gap metabolic acidosis. It is also, that's what it looks like. It looks like a very good divalent cation chelator. So you have a negative charge here, you have a negative charge here, and in fact calcium fits very nicely into that pocket to form calcium oxalate. Calcium oxalate is insoluble, it precipitates out, so that's going to contribute to the cardiac toxicity, and it's also going to contribute to the renal toxicity. So think about causes of osmolal gaps and anion gaps and how we pick up toxic alcohols. Thanks for listening.